Hi, this is a very important topic. Okay, I won't go into too much detail as I've made this video specifically for the upcoming NEET-PG exam, which is within a week. So, this is on request of many students. We will discuss screening of cancer cervix and management of pre-malignant diseases of the cervix. What you need to know for the exam. Okay, so it's a very brief overview. Let's start. Okay, first things first, what do we test when we talk about cervical cytology or pap smear? What are we testing? So we are testing, so it's important to understand this concept. So at birth, if you look at the cervix and the vagina, this is what is there. So there is the cervix is lined, the endocervix is lined here, as you can see, with endocervical epithelium, right? And here the ectocervix is by squamous epithelium. All right. What happens now as the woman progresses in age? In the young adult, what happens? There is eversion of the cervix. So there is now columnar epithelium is coming and lying outside. So on the ectocervix. Okay. So this is called an ectropion with exposed columnar epithelium. Now what happens is over age, further as her age increases, this exposed columnar epithelium undergoes squamous metaplasia. That means the cells now with those columnar epithelium which was exposed, that is the ectocervix, this undergoes metaplasia, and this area is called the transformation zone. Okay, so that area which is between the old squamocolumnar junction and the new squamocolumnar junction, right from here till here, is called the transformation zone or the TZ. And this transformation zone is very prone to malignant change. Okay, so it's undergone metaplasia, and this is where most cancers of the cervix will happen, and that's why we do a cytology from this area. And when you do a colposcopy, we see this area, the transformation zone. All right, so moving on, this is how the transformation zone looks like. Okay, so you can see, sorry, let me just go back. Yeah. Okay, so this is how the transformation zone looks like. The yellow outline at the towards the periphery is the old squamocolumnar junction, and this blue thing inside, this blue line, is the new squamocolumnar junction. So the area between the yellow and the blue line is called the transformation zone. Now, coming to cancer screening. So, the American Cancer Society, and this is as recent as 2020, has advised the following. So, it says don't need to screen before the age of 25. Screening for cancer cervix should start at the age of 25 onwards, and from the age of 25 to 65, what do we do? The preferred test now is primary HPV. It's not pap smear. Remember this. The primary test, the preferred test is now the testing for the human papilloma virus, because we all know this is the causative organism for cancer cervix. And how often do we do it? We do it every 5 years. What else can we do? We can do a pap smear. If you're doing a pap smear, do it every 3 years. And if you're doing a co-test, what is a co-test? You're doing both. You're doing HPV and a pap test. That also is every 5 years. But the preferred modality is now doing an HPV. It's not doing a cytology. If the HPV is positive, then we do a cytology, and we can stop screening at 65 years if the previous two tests were normal. What does the WHO suggest? And this is as recent as 2021. WHO says for general population, same thing. Start at the age of 30 years. HPV DNA is the primary screening test. Okay, it doesn't say cytology. Remember, it says HPV DNA is the primary screening test, starting at age 30, and again every 5 to 10 years. And for women living with HIV, it says start at the age of 25 years and do the HPV DNA every 3 to 5 years, because they are at an increased risk of developing cancer of the cervix. Now, how do we test? Quickly, let's discuss this. How do we test? This is called a, we can either test as I mentioned as a primary HPV, or we take a pap smear. This question has been asked in the last INICT, I think. The instruments required for a pap smear. What all do we require? We require a Cusco speculum. Okay, this is a Cusco. This is a disposable Cusco speculum. You can also have the metal a cusco speculum. We have the iris spatula and a cytobrush. We have the slides and we have the fixative in this jar. So this is what is required to take a pap smear. I have a small video on how to take a pap smear. So let's just see this. Okay, so you can see the cuscos has been placed. That's the cervix. You can even see the transformation zone. The iris spatula is introduced, rotated twice. Okay, and then it is the smear is made. Okay, on the slide, it's handed over to the sister. Then this is the cyto brush. It goes inside the endocervix, and you can see that it has been rotated. And this again is given to the nurse, and the nurse then prepares the slides, and then she dips it in the fixative. So this is how a pap smear is taken. All right. Okay. Now moving on. Okay, so this is, and how you might wonder, how is an HPV test taken? So cyto brush is used, okay, like we use for liquid based cytology. Okay, the same cyto brush is used. It has a sort of, it's like a broom. It has a pointed end, but they're all bristles at the tip. So you sweep around the cervix, and this is sent in a media, and then HPV testing is done. Okay. Now, what are the other methods of testing? In this question is also commonly asked in low resource settings, like if you're in the primary healthcare center, you don't have a pathologist, you don't have a laboratory, patient comes to you, you don't want to lose her to follow up, you don't want to call her again. What can you do? You can do two things. You can do visual inspection with acetic acid, okay, and abnormal areas will appear aceto white because of denaturation of protein in abnormal cells. Okay, so this is aceto-white area you can see here on the anterior part of the cervix. We can also do villi. What is villi? Villi is visual inspection with Lugol's iodine. So you can see abnormal areas will appear this mustard yellow color. The normal areas will appear brown. So this is the same patient has an aceto-white area and has a deficient iodine uptake at this area. So this is the area where we need to take a biopsy from. This is the abnormal area. There's one more thing called VIAM, which is visual inspection with acetic acid under magnification. So these are the two tests or three tests which can be done in low resource settings. Okay, and what are the combined tests? Combined tests, we already talked about co-testing, which is HPV plus cytology, that is a pap smear. We do both. What is reflex testing? Reflex testing is we take both the samples. You may come across this terminology in books. We take both the samples. We take a sample for HPV, we take a pap smear also. But we first do HPV, and if it is positive, then we do the cytology. Then only we test. We've taken the sample, we've kept it, but we test it only if the HPV is positive. So these are the types of combined testing that we have. Now let's talk about classification or abnormality. So if we take an HPV, it can be positive or negative. If we take a pap smear, what are the different abnormalities we can have? So we can have NIELM. You must have come across this. This is normal. This is negative for intraepithelial lesion or malignancy. And this is a normal finding. You can have epithelial cell abnormalities and you can have glandular cell abnormalities. Okay. So what are the epithelial cell abnormalities? As I said, negative could be, this is a normal finding. Ascus means atypical squamous cells of undetermined significance, and this is usually a mild abnormality. Okay, it doesn't have much significance. Ask H is important. Ask H is atypical squamous cells cannot exclude high grade squamous intraepithelial lesions. So this is an important finding. L cell is low grade, H cell is high grade, or you can actually find carcinoma, squamous cell carcinoma on a pap smear itself. Okay. So these are the epithelial cell abnormalities. In this, remember, ascus, L cell are relatively milder. Ask H cell are the higher grade. Okay. Glandular cell abnormalities, you could have atypical glandular cells. Okay. You can have directly adenocarcinoma in situ. Both are obvious, of course. Atypical glandular cells are also not a good thing to have. They indicate further evaluation is required. And of course, if you get in situ lesion, you will obviously further evaluate. Now, what do you do if you get an abnormal HPV? As I said, HPV can be positive or negative. So, if the HPV is negative, nothing needs to be done. So, return to routine 5-yearly screening. But if the HPV is positive, that means then three things you could do. Okay, you can do a cytology. Okay, that is, see if the pap smear was taken, well and good. If it's not been taken, call her for a pap smear. And if it is anything above ascus, okay, so HIV positive with any ascus, L cell, H cell, anything, you do a colposcopy. Okay, or another thing you can do is you can check the genotype. If you have the facility, if you have the equipment, do a genotype. If it is 16 or 18, these are the highest risk categories, then again do a colposcopy and biopsy. Or you can, even if HPV is positive, you don't have a cytology, you can directly call the patient for a colposcopy and biopsy. If you, especially if you feel the patient will not come again. Some patients will say, you're calling me repeatedly. You first called me for an HPV, now you're calling me for a cytology, now you're again going to call me for a colposcopy. So you can skip the step and directly do a colposcopy and biopsy. So basically, if HPV is positive, it is important. You cannot ignore it. You have to proceed to colposcopy and biopsy or do a cytology. And if it is abnormal, any finding, do a colposcopy and biopsy. Okay, now moving forward. Okay, now what do you do if the cytology is abnormal? So we've discussed abnormal HPV, that means HPV positive or negative. What do you do if the cytology is abnormal? So what are the abnormal cytologies we can have? We can have ascus. Ascus is atypical squamous cells of undetermined significance. Remember, I said it is one of the milder varieties. Ascus and LCL are milder. If ascus with HPV positive status is there, do a colposcopy and biopsy. And if it is HPV negative, then nothing to worry. You can just return her to normal testing. Okay. Now, if it is LCL, that means low-grade squamous intraepithelial lesion. Again, it's relatively mild. So, if she's HPV positive, again, colposcopy and biopsy, same thing. If she's HPV negative, you can return to testing, but repeat the cytology a little earlier at 1 year. Okay. Now, if she's HCL or AskH, then what do? You will directly do a colposcopy and biopsy irrespective of the HPV status. Okay, you may or may not have done a co-test. You may or may not need to do it because it's now come as HCL, which is important. You can't ignore this. Even if the HPV is negative, you can't ignore this. You will do a colposcopy and biopsy. I hope this is clear. So as CUS and LCL are the relatively milder variety. So if they are negative, you don't have to do a colp. If they're HPV negative, you don't have to do a colposcopy biopsy. Only if they're HPV positive will you proceed for colposcopy and biopsy. But if it's HCL or AskH, directly called to a colposcopy and biopsy. Now this is a very important point to remember. On pap smear, you get these findings: ascus, askh, LCL, HCL. When you take a colposcopy and from the abnormal looking areas, take a biopsy, that histopathology will be reported as CIN 1, 2, and 3. Remember, CIN, cervical intraepithelial lesion, is neoplasia, is not a pap smear finding. It used to be a pap smear finding. So your older MCQs, you will say pap smear reports CIN to what to do next. Those are older questions. If you get a question now, okay, nobody will ever ask you this. So management of so when you talk about taking a cervical biopsy, then the reporting will be CIN 1, 2, and 3. If you take a pap smear, the reporting will be NIELM, ASCUS, HCL, LCL. Okay, I hope this is clear. So now we've say a patient with HCL came to us, we do a colposcopy, we find an abnormal area, we take a biopsy, and that gets reported as CIN 1, 2, or 3. Now what do we do? So we can have CIN 1. If it is CIN 1, what do? CIN 1 is a milder lesion. So you can not do anything. Okay, so do a co-test. That means repeat HPV and pap smear after 1 year. But if you feel the patient will be lost to follow-up or she may not come or she's very anxious, you can also offer her an ablative procedure. That means you're going to ablate the tissue. You're going to destroy the tissue. We'll come to a little bit more detail about ablative procedures. If she's CIN 2 or 3, now CIN 2 or 3, the risk of progression to cancer is higher. You can't just leave her and call her again. You have to do either an ablative procedure or an excisional procedure. Okay. And an excisional procedure means you're removing the tissue. Ablative procedure means you're destroying the tissue. Which you think is better? Removing an abnormal tissue is obviously better. Less chance of recurrence. And what is the preferred method of excision? Is what is called a large loop excision of the transformational zone. So LEEP is basically loop excisional procedure, and the main type, it's actually the same thing. Large loop excision of the transformation zone is a type of LEEP. Okay, so this is using electrocoagulation. We take out a bit of the transformation. We take out the transformation zone and a bit of extra cervical tissue. So that's what a LETS is. Okay. Ablative procedures can also be done, but only if these criteria are fulfilled. So say she's come at CIN 2 or 3, you prefer to do a LETS. Okay, that is an excisional procedure, but you can also do an ablative procedure if you can see the entire transformational zone. If you're sure there is no endocervical extension, if she's not pregnant, obviously, and if there is no suspicion of cancer, then you can also offer ablative procedures, but the treatment of choice for CIN 2 or 3 is LEAP or LETS. Okay. Now, what are the ablative procedures? You can ablate using, you can use to destroy tissue. How can you destroy tissue? By using heat, that is thermoablation, or cryotherapy, that is using cold. And what do we use? We use nitrous oxide commonly. This is how the cryo probe, that is the cold, is applied over the cervix. This is the probe. Nitrous oxide gas is applied at minus 89 degrees, and we freeze for 3 minutes. Then thaw. The machine has a freeze thaw cycle. So one freeze thaw, then one more freeze thaw. So two cycles. Freeze for 3 minutes, thaw for 5 minutes, freeze for 3 minutes, thaw for 5 minutes. That's how it's done. And what does this do? It leads to a depth of destruction of 5 millimeters. Thermal ablation leads to a depth of destruction of 5 to 7 millimeter. Cryo leads to a depth of destruction of up to 5 millimeter. We can also do laser ablation using carbon dioxide laser. Okay, so you can get an image like this and they can ask you what is this? This is cryo ablation. Now, excisional procedures. So this basically means excision of the transformational zone, including a portion of the endocervical canal. And as I said, the LEAP means loop electro-excisional procedures. And in that, LETS is the treatment of choice. This is large loop excision of the transformation zone. So if someone asks you treatment of choice for CIN 2 or 3, the answer is LETS if given. Otherwise, LEAP, either of the two, whatever is given in the choices is the answer. What else can you do? You can also do a cold knife conization. What is a cold knife conization? Cold knife means you're not using energy. So it's cold knife. Whenever you encounter the word cold knife in surgery, it means you're using a scalpel. So you're removing a cone of the cervix by using a scalpel. You're not using any thermal energy source. When will we do a cold knife? If the lesion is extending into the endocervix, if there is a difference, gross difference in the cytology and histology. Say the cytology comes as HCIL, but the biopsy comes as CIN1. So that does not correspond. HCIL, you will expect it to be CIN 2 or 3. So there's some doubt now. Cytology is showing a higher lesion, but histopathology is showing a lower lesion. That means you may have missed an important area in your biopsy. So how can you cover for that now? You can do a cold knife conization because compared to a LETS, cold knife removes more area. Okay, or you suspect cancer, or it is recurrent edge. As a patient comes with recurrent despite a LETS, she again comes with an edge cell. Okay, so then you do a cold knife conization, or you can do a laser conization. So I'll just show you the pictures. This is a picture of LETS, large loop excision of the transformation zone. This is the instrument. This is the electrocautery. So you just sort of brush it over the cervix and it excises this part of the cervical tissue with a bit of the endocervix. This is the transformation zone being excised. This is a cold knife conization. You can see now this with a knife, with a scalpel, you're taking a cone or a wedge shaped area of tissue is removed, including more of the endocervical canal. And so a cone biopsy is done when you suspect that this patient may have a lesion inside, that is endocervical extension, or as I said, there is discordancy, or you suspect or she has recurrent high grade lesions. Okay, so LETS is the treatment of choice, but cold knife you will do in a more higher, where you suspect, where you have a higher index of suspicion. Okay. Now, other few important points to remember. If the So when you remove this LETS, when you remove the transformation zone, you will again send it for histopathology. And if the margins are negative, that means you've probably removed everything. But still, you can't leave the patient alone. She has to come back for co-testing at 12 months, 1 year, and at 2 years. But if the lead specimen shows margins positive, that means some amount of CIN 2 or 3 is still left behind. What should you do next? You should repeat the excision or directly do a hysterectomy. Okay, so this is what you'll do if the margins are positive. Now, you can directly do a hysterectomy also in CIN 2 or 3. When is this? when there is adenocarcinoma in situ, when the CIN3, as I said, patient margins come positive, you can directly do a hysterectomy, or you feel the woman won't come for follow-ups, you can directly do a hysterectomy. Or again, if she has recurrent high-grade lesions, you can do a cone biopsy, or you can do a hysterectomy. Okay, now this is just a graph to show you how CIN progresses to cancer. Okay, so CIN1 mostly will recur back to normal, but it has a 1% chance of progress to cancer cervix. CIN2 again can convert back to CIN1 and then convert back to normal, but it has a 5% risk of progression to cervical cancer. And CIN3 has a 10 to 12%. So remember these numbers: 1% CIN1, 5% CIN2, 10% CIN3, that is the risk of progression to cervical cancer. And last but not least is CIN in pregnancy. Rare, but you may get a question on CIN in pregnancy. What do you do? So if you get CIN pregnancy and it is a low grade lesion, okay, what will you do? You will follow up with colposcopy at 6 weeks postpartum. So nothing doing, let her deliver, call her at 6 weeks and do a colposcopy. Okay, but if it is a high grade lesion on colposcopy, what will you do? That is CIN 2 or 3. What will you do? You will repeat colposcopy at every trimester. You basically don't want to miss out malignancy. So every trimester, every 3 months, keep calling her for colposcopies if she's CIN 2 or 3. And if it remains CIN 2 or 3, then after 6 weeks, after she delivers, review and treat her as per previous guidelines. That is, do an excisional procedure or an ablative procedure, preferably an excisional procedure. The third option is she directly comes as invasive cancer. Then, depending on the period of gestation, you have to treat her. Then you can't wait for her to deliver. You have to take action immediately if it comes out to be malignancy. So, I hope this video was helpful. Please subscribe to my channel for more useful videos. And good luck, everybody, for the upcoming NEET-PG exam.